Now we have Dr. Sanjay Chaudhary. He'll be talking on pearls to optimize patient outcome with the EVO ICL. I think Dr. Sanjay Chaudhary needs no introduction, and he's one of the largest ICL users in India. All to you, Dr. Chaudhary.
Thank you, Dr. Sonugal, for that kind introduction. When I was looking at what I think I should talk about in this session, I realized that there's a lot of confusion regarding the sizing. And sizing is the primary area of problem because there are so many options. So probably a review of how we can get more and more accurate on the sizing is and understand the fundamentals of how we go about it. So the first problem, we are all told that we have to measure a white to white. So this is a white to white, and on the left side is the sizing. The OCOS system, which shows that from this size to this size you use 12.1, 12.6, 13.2, and 13.7. Now, the problem is, from 11.14 size to 11.15 size, 0.01. There's a sudden jump of size. And this is more relevant in the small eyes where the jump is very steep from one side to the other side. In the bigger eyes, it is less of a problem. So, we'll see what we can do about this. And then, if you notice another thing, it was just an observation that on this chart, if you look at the last figure, 11.4, in the white to white, and you add 1, it becomes, 11.1, you add 1, it becomes 12.1. 11.6, it becomes 12.6. 12.2 becomes 13.2, and 12.7 becomes 13.7. It's just an observation that actually you're adding 1 millimeter to the maximum value of that range. Just an observation. Maybe that observation helps in a future discussion. Okay, now white to white. It is the main parameter for ICL sizing today. And it also happens to be the most variable parameter. Like Thomas just said, you do white to white 10 times, then you get different results. And that is actually a fact. Not only on one machine, but if you have different modalities, you will have different results on all the modalities. For example, for years, we have been using this concept that when you do a digital caliper, if the size is 11.7, and on Pentacam, it usually shows up at 11.9. And in optical biometers, it shows up as 12.2. That's a huge difference. Now, which reading will you take? That's the dilemma with us. That with such a long range, what reading would you take? And you know what? That's the biggest surprise. And we have accepted that surprise. Is that all the above readings are correct. All the above readings are correct. So that's the bigger confusion. And Pentacam is close to the digital caliper and is more by 0.2, and optical biometer is about 0.4 more than the manual digital correction. But this is, we have been made to understand that all these readings are similar, and you can just go ahead with the same sized ICL. The other dilemma which we have been facing is what is actually a white to white. Look at this diagram on the left. Here is one white to white on the top, which is from the true area where the sclera starts. At the bottom is one white to white, which you can call is clear to clear. And in the middle is another white to white called mid to mid. When we started off, we said the clear white to white is what is called the horizontal visible iris diameter. And this is what we are supposed to use. Then it said, no, the real one is the outer one, but outer one becomes too big. That means outer one is the true white to white, and it becomes too big, so you use the mid to mid, and that is the best way to go. And now if you talk to 10 people, all of them would be promoting a different white to white. Even as of today, nobody is exactly sure which is the right white to white. And this is where an OCT comes to our rescue now, the AIOS-OCT. It has taken away that manual element, and the ray tracing systems or other ways of capturing has given us some idea of where we actually stand. Let's see how. So, yesterday when I was giving my talk on ICL, a lot of people asked me, sir, why don't you just explain to us about these OCTs, AIOS-OCTs, and its sizing? Because all these formulas are using spur to spur, angle to angle, white to white. And we really don't know how to go about it. So will you just give us the anatomy of an AIOS-OCT? I thought probably this slide might be useful. So I just put it in yesterday. So let's see, just a basic understanding. The cornea, epithelium, stroma, endothelium, anyway, not much of interest here. Conjunctiva there, sclera there, and trabecular meshwork. This is of interest. So the trabecular meshwork, if you look at it here, it is attached to one point here, which is the scleral spur, and it finishes off here where there's a Schwalbe's line. Right? OCT trabecular meshwork zone is very clearly defined. So this is the limbus. So in the limbus, if you're doing your surgeries, you have this conjunctival area also, you have the scleral area also, you have the trabecular meshwork area also. But when you're doing your cataract surgeries, you are not piercing the trabecular meshwork. Why? Because you give a little incision here, which is 0.3 millimeters, straight incision, and then you take it parallel to the iris. So you come out in front of the iris. Right? Now, this is the scleral spur, a very important landmark for us when you're doing the ICLs. And the ciliary body, the interior chamber, and the angle. These two are very important landmarks for us. This is the angle, and this angle of 30 degree is an open angle. So you have to learn to recognize the angle, you have to learn to recognize the scleral spur. If you have to really move on to get a right sizing and use the AIOS-OCT in the best possible way. Okay, then let's go. Now this is the AIOS-OCT. Now, I'll spend a little time, but this is the crux of this talk. This AIOS-OCT says, look down here, in the violet zone. This says 12. I'll take another 3-4 minutes. Just explain this slide. This says 12. Now, if you put 12 here, you find that this V zone, let me show this here. You see this is the cornea, which is fitting into the sclera, and there is a V zone. Now, this point of the V is where it is all sclera, and this is the true white to white. This part of the V, which is more or less no sclera now, is clear to clear, and the mid is between these, right? So, if I put the marker on this V here and this V here, this is the white to white. What AIOS-OCT is taking, and it's taken here as 12, so it's put here as 12 millimeters. Now the AIOS-OCT automatically takes the spur and the angle-to-angle calculations on its own. So spur is in yellow, and this is spur in yellow, and this is 11.59. More or less the same as the white to white. White to white often is just a 0.1 millimeter more than the spur to spur. Look at angle to angle, 11.56, 11.86, sorry. Now, angle will always be a little more than the spur because the eye is going in like this. By default, it has to be a little more, approximately 0.2 more. If you understand these dynamics, the white to white where it actually is, because when the rays of light are coming out of the eye, the area which is, the rays are totally blocked. That is the white to white. White to white, angle to angle, spur to spur. If you have these fundamentals right, look at this option. Another option says that in this capturing, I could capture spur to spur. Spur to spur comes out very easily in all AIOS, but it is not a must that angle to angle comes out in all. Angle to angle capturing is sometimes missed in almost 30% of the capturing. So probably your spur to spur and angle to angle and white to white, since the differences are not major, and the reproducible matrix is spur to spur, then all formulas which are related to spur for calculations would probably do well. But if you look at this, white to white is a very variable metric, very variable. Technically, I would say it is fairly useless. When acquired by different methods like calipers, pentacam, and optical biometers, on AIOS, it is a shade larger than SSD. SSD is spur to spur, right? Sulcus to sulcus would have been an ideal parameter. It is captured by the high-frequency ultrasound. It is highly user-dependent. It loses its importance because of its variability, because there's an individual factor to it, patient discomfort, and a long capturing time. Now, I recently went to Korea, visited some South Korean ophthalmologists. One ophthalmologist only runs an ICL clinic, ICL center. He doesn't do anything else, just does ICL. We're talking to him, he said, "Sir, we have stopped using the ultrasound. We are totally on AIOS." And spur to spur is the most reproducible and a consistent metric. And angle to angle is a shade more, but not as reproducible a metric as compared to SSD. Can be difficult to calculate in narrow angle situations. However, if you can calculate it as a routine, it is the best metric. Why? Because the angle to angle very clearly corresponds to the sulcus to sulcus, because they are both uveal tissue, both based on the root of the iris. One is in front of the root of the iris, one is at the back of the root of the iris. So if you have to say which will match most the sulcus to sulcus, it should be angle to angle. Both are uveal tissues at the root of the iris. I'm just talking about a very fundamental thing, and probably I'll just finish it off. Crystalline lens rise is another important metric. This is typically angle to angle line and the front part of the lens. So if you look at this, lens rise, here it is seen as lens vault, is minus 0.25 millimeters. That means 250 microns. So it is typical, this red line, angle to angle, and this front part of the lens. And this difference is 250 microns. It is minus because it is below the line. If it is beyond the line, it would become plus. Understanding these metrics, here is what I picked up from one of the journals, JCRS. And they said that 11.56 is what is from this part of the V to this part of the V. So the journals are also talking about what is actually a true white to white. So I would recommend, even now when you're using your calipers, use the real outer white to white. The time has gone when you're using clear to clear. The time has gone when you're using mid to mid. The time has come when you're going to use outside to outside, because that is the one which is metric which is going to match your OCT white to white.
So can I request you to please summarize?
Yeah, sure. half a minute?
Yeah.
And I'll just finish it, right? So ICL position is independent of crystalline lens rise. A very important statement. That means the ICL is going to come in the sulcus. It is going to take its own curve or vault. It has got nothing to do with the crystalline lens. Crystalline lens is just lying below. But the vault becomes relevant because if the clear lens rises high, for the same ICL position, the vault will be less. If the crystalline lens rise is low, for the same IOL position, the vault will be high. And whenever you're using a formula, it is more dependent on the sizing and the vault. It is comparatively less dependent on crystalline lens rise. So I think there's a formula dilemma. 90% of the ICL surgeons are still using the OCOS formula with the white to white as a standard. I would suggest that it is time we moved on to the next level and base all our findings on AIOS2025. And another thing which I found very useful, the last point I want to show to you, that even though you follow the NK formula, KS formula, or the lasso formula, they're just giving you ready AI answers. But sometimes those answers may not be correct. And you have to use your logic. And if you have to use your logic, one simple way would be calculate a spur-to-spur distance, add 1 to it, and that value we have used in a number of cases where there was a doubt really works out to be the right value. But so it is that surgeons are not robots. They still have to use their intelligence and sometimes think out of the box to get the right vault. Thank you so much.
Thank you, Dr. Sanjay Chaudhary. So I think it's not the artificial intelligence, it's the human intelligence which actually works.
True.
Isn't it frightening for the new beginners? This type of calculation will be frightening for the beginners.
So
I think
AIOS2025 these days are with most of the doctors because OCT is with everybody. Probably 90% of the practices have OTCs now, OCTs now.
Meanwhile,
So all those have AIOS2025s.
Meanwhile, I'll
There's
request
only a
Dr.
question
Sudarshan
using
Kokar.
it.
Sir, please, because you have another talk. So I'm sorry to interrupt.
Yeah.
You can continue. Meanwhile, you just you can
So
answer that.
AIOS2025 is just a matter of getting into it. It's there with all the practitioners now. Once you start getting used to that idea of doing the spur to spurs and basing your calculation on that, and then see what the star formulas give you and whether you agree with that or not. Most of the times, you really come up with the right size, different to what was recommended by the standard OCOS formula. Thank you.